Welcome to eNormous Nephrology. This is volume 3 of an 8-session board review designed to jumpstart enormous nephrology. And then subsequent sessions will be devoted to individual in-depth topics of interest to the medical community and that are designed to stimulate minds and excite people to investigate and learn nephrology in detail. So this particular session will be devoted to calcium, magnesium, phosphorus, and acid base. Next slide. So let's start with calcium. Next slide. In order to understand calcium, you have to understand the enzymatic processes involved in regulating calcium. The most important thing is that vitamin D deficiency will lead to decreased calcitriol levels. And in chronic kidney disease, there's decreased activation of vitamin D. So there are multiple reasons for decreased calcitriol levels. Decrease in calcitriol levels will decrease intestinal calcium absorption and will also decrease stimulation of the calcium sensing receptor, leading to hyperparathyroidism. And this is secondary hyperparathyroidism because this is secondary to vitamin D deficiency and secondary to hypocalcemia. The other thing to remember is that phosphate overload is very important, especially in chronic kidney disease. Phosphate overload will increase the levels of FGF23. FGF23 is a burgeoning enzyme in nephrology and in physiology. It is currently available in research centers, but may become a laboratory test that's available in all medical centers. FGF23 will be tested on the nephrology boards and in potentially on the internal medicine boards as well. So phosphate overload will stimulate FGF23, which will then cause 1-alpha hydroxylase inhibition, leading to decreased calcitriol levels and mitigation of phosphate overload. Phosphate overload can directly affect calcitriol levels as well. And phosphate, some would say, can actually be sensed by the calcium sensing receptor, directly having an effect on PTH levels, thereby increasing PTH levels. Next slide. Understanding calcium and calcium sensing receptor requires understanding of the channels that are involved. These are the tubular cells. And it shows the NKCC2, the sodium potassium 2-chloride cotransporter, the calcium sensing receptor. So the calcium is sensed by the calcium sensing receptor, and the result is that potassium excretion is blocked. In normal processes, the sodium potassium chloride electrolytes are conserved, and the potassium is excreted to maintain potassium homeostasis. The resultant excretion of potassium causes an increase in the positive charge, causing the calcium to be absorbed. Presence of calcium will therefore block the excretion of potassium and prevent the increase in positive charge and prevent absorption of calcium. So this is passive transport of calcium. Similarly, the calcium is sensed by the calcium sensing receptor. Cyclic AMP is blocked, and therefore stimulation of PTH is blocked, and absorption of calcium is also blocked, resulting in prevention of excessive calcium levels or hypercalcemia. Next slide. So let's talk about hypocalcemia. What are the causes of hypocalcemia? Hypoparathyroidism is a common cause of hypocalcemia with the resultant decreased calcium release from bone. It's typically autoimmune, but is present in hungry bone syndrome, in which calcium shifts into the bone for remineralization, status post-parathyroidectomy. We'll talk about hungry bone syndrome a little bit later. Vitamin D deficiency obviously causes decreased gut calcium absorption. Gut malabsorption can cause intestinal disease and malabsorption of calcium. And then, as we talked about, in renal failure, you're going to have hypocalcemia. The hypocalcemia is mainly due to vitamin D deficiency with subsequent activated vitamin D deficiency, but also because of decrease in the number of vitamin D receptors and resistance to the activation of vitamin D. Phosphorus retention leads to an increase in FGF23 production, which inhibits renal 1-alpha hydroxylase in the kidney. Hyperphosphatemia per se results in an increase in the calcium phosphorus product in blood and favors movement of calcium into tissues, particularly bone. Next slide. So secondary hyperparathyroidism, you should think classic triad: hypocalcemia, increased PTH, and high phosphorus. Rhabdomyolysis results from muscle breakdown, releasing phosphorus into the extracellular fluid, and is typically associated with severe hyperphosphatemia, resultant profound hypocalcemia, partly due to deposition of calcium in damaged muscle. In acute pancreatitis, calcium fatty acid precipitation is the cause of hypocalcemia. Hypomagnesemia does decrease PTH release as well as decrease peripheral action of PTH. And then medication-wise, you should think about bisphosphonates, cinacalcet, and citrate, which are common causes for hypocalcemia. Next slide. How do you treat hypocalcemia? So the most important thing to remember is what's dangerous, what's critical. Ionized calcium less than 1.0 millimoles per liter is critical, and total calcium less than 7.1 milligram per deciliter. So typically, if it's critical, you can supplement with intravenous calcium gluconate. And if it's resistant to supplementation or very difficult to correct, a continuous calcium infusion may be needed. Typically, you add 100 milliliters of 10% calcium gluconate to 1 liter of D5W. Start at 50 milliliters per hour, and then adjust the rate as needed to achieve a calcium level which is not critical. In hungry bone syndrome, this is typically one of those syndromes that does require calcium infusions. So you should do continuous calcium infusion. Calcitriol, PO or IV, up to 4 mics per day. If the patient ends up on hemodialysis, you should use a high calcium bath, which is a 3 calcium dialysate bath, and avoid phosphorus supplementation unless the serum phos is really low, typically less than 1.0. Next slide. So now let's talk about hypercalcemia. When we think about hypercalcemia, we typically think about primary hyperparathyroidism, which implies that the parathyroids are producing excessive PTH, either because it's an adenoma or because it's hyperplasia. In secondary hyperparathyroidism, calcium is typically low, but if you have prolonged disease and you have adynamic bone disease, and you're on calcium-containing phosphate binders, which were used to treat hyperphosphatemia, you may end up with hypercalcemia in rare cases, but that would require prolonged disease, adynamic bone disease, as well as calcium-containing phosphate binders. Tertiary hyperparathyroidism is defined as hyperparathyroidism that fails to resolve with maximum medical management, or hyperparathyroidism that persists despite renal transplantation. In tertiary hyperparathyroidism, basically you've had secondary hyperparathyroidism for such a long time that the parathyroids become autonomous, and even after calcitriol and calcium supplementation and treatment of secondary hyperparathyroidism, the hyperparathyroidism fails to resolve. So one would expect that after transplantation, that the bone mineral metabolism axis would improve, but sometimes it does not because of tertiary hyperparathyroidism. Vitamin D excess does occur actually quite commonly, and it can increase gut calcium absorption. The typical vitamin D goal for secondary hyperparathyroidism is 50, not much more than that. The usual goal of 30 is not actually the recommended goal. The goal of vitamin D that you want to accomplish is about 50, but not 80 or 100, which can sometimes be seen. Malignancy has multiple mechanisms, including bone resorption, ectopic PTH secretion, and secretion of PTH-related peptides, all of which can be measured. Next slide. Less common causes of hypercalcemia would be granulomatous disease, also lymphoma, and things like tuberculosis, fungal disease. And in these disease processes, there's increased activity of the activated vitamin D or increased production of the activated vitamin D. And the calcitriol level or the activated vitamin D level should be measured to see if these processes may be occurring. Immobilization causes increased calcium release from bone. So that is actually probably one of the most common causes for hypercalcemia is prolonged immobilization. Familial hypocalciuric hypercalcemia is an inactivating mutation of the calcium sensing receptor in the parathyroid glands and kidney tubules. And this is a higher set point for plasma calcium to suppress PTH release. So you have hypocalciuria because you have increased renal calcium reabsorption, and you have hypercalcemia because there's a higher set point for suppression of PTH release. Medications such as thiazides, which decrease urinary calcium excretion, lithium, which increases PTH release, as well as calcium plus alkali, are also common scenarios that are encountered in the clinical setting. So how does one distinguish between primary hyperparathyroidism and familial hypocalciuric hypercalcemia? The main thing is hypocalciuria. We already talked about the metabolic basis of familial hypocalciuric hypercalcemia. Basically, so you want to prove that there is hypocalciuria. So that means the 24-hour urine calcium or the urine calcium to creatinine ratio is low, less than 200 milligrams, or the calcium to creatinine clearance ratio. These calculators are readily available on the internet, should be less than 0.01. The fractional excretion of calcium should be less than 1%, whereas in primary hyperparathyroidism, the urine calcium excretion is greater than 200 to 300 milligrams per day. The calcium to creatinine clearance ratio is greater than 0.02, and the fractional excretion of calcium is greater than 2%. You can use any of these. Typically, the 24-hour urine is too laborious and impractical. I personally feel that the urine calcium to creatinine clearance ratio is the most useful. The calculator is readily available, and all you need is a urine calcium and a urine creatinine, as well as serum calcium and serum creatinine. Next slide. So if you do have primary hyperparathyroidism, when do you do a parathyroidectomy? You don't always resort to surgery, obviously. The main indications would be symptomatic hypercalcemia, or if they're asymptomatic, plus the serum calcium is elevated by 1 milligram per deciliter or 0.25 millimoles per liter. If there's acute kidney injury, if there's osteoporosis, or if the patient is young. If the patient is greater than 50 years old, typically conservative management is indicated. And if you really need to reduce the calcium and the patient is a poor surgical candidate, then you can use cinacalcet, which activates the calcium sensing receptor, causing reduction of the serum calcium level, bisphosphonates, or vitamin D analogs, which may suppress PTH, so caution is advised. Next slide. Treatment of hypercalcemia, you should not be reflexive in your treatment of hypercalcemia. If the calcium is less than 12 or even 12 to 14 and the patient is asymptomatic, you don't have to jump to treatment. You can think about it, figure out the cause, and then treat the hypercalcemia non-urgently. If the calcium is greater than 14 milligrams per deciliter, then you should start normal saline at a high dose, initially 200 to 300 milliliters per hour, then a maintenance dose. You should start calcitonin But remember that calcitonin has an immediate effect, so it is important. It brings down the calcium very fast, but it is subject to tachyphylaxis, which means that after 24 hours, it will no longer be effective. So even though you use calcitonin for the immediate effect, you have to have a plan for long-term calcium reduction. Next slide. And that's where bisphosphonates play a role. After about 2 to 4 days, the bisphosphonates begin to cause calcium reduction. The bisphosphonate of choice is zoledronic acid, 4 milligram IV single dose, which can be repeated in 7 days. But zoledronic acid is contraindicated with GFR less than 35. And in those instances, I've used pimidronate very successfully. You can give 60 to 90 milligrams, but you just have to give it very slowly, typically over 2 hours. And nursing staff is aware of how to do it very slowly to avoid kidney injury. If there's severe kidney impairment or a bisphosphonate allergy, then you can use denosumab, which is the newest agent in the treatment of hypercalcemia. If the calcium is 18 to 20 milligrams per deciliter, then hemodialysis typically becomes necessary. Next. Denosumab is a recently approved therapy. It's a fully human monoclonal antibody that binds the cytokine RANKL, receptor activity of NF-kappa B ligand, which is an essential factor initiating bone turnover. RANKL inhibition blocks osteoclast maturation, function, and survival, thus reducing bone resorption. It's actually very effective, and hypocalcemia is actually a common adverse effect of denosumab, so close monitoring is indicated. Start with 60 milligrams sub-Q times 1 dose. Sometimes maintenance is required, and that would be 120 milligrams weekly times 3 weeks, followed by monthly. Next slide. So let's go on to phosphorus. We'll talk about low phosphorus. Causes of hypophosphatemia would be shift into cells, which would be insulin. Refeeding will stimulate insulin release. Respiratory alkalosis causes intracellular pH and stimulates glycolysis and ATP production. And as we talked about, hungry bone syndrome, the phos will shift into the bone for remineralization, status post parathyroidectomy. Next. Renal losses can occur. Primary hyperparathyroidism would be a decreased proximal tubular phosphate absorption. FGF23 overproduction does exist, and this will decrease proximal tubular phosphate absorption. Vitamin D deficiency, as in secondary hyperparathyroidism, and then renal tubular disorders such as Fanconi syndrome, in which there's decreased proximal tubular phosphate absorption. Next slide. Gastrointestinal absorption can be affected, as in malnutrition, decreased gut phosphorus absorption, as in vitamin D deficiency, malabsorption, and if you're taking phosphorus binders, including the over-the-counter magnesium and aluminum containing antacids. Treatment of hypophosphatemia is to treat the underlying process. So you just have to recall the various etiologies that are possible and that are clinically relevant. If you need to supplement phosphorus, typically you can use Nutriphos if it's mild, or intravenous potassium phosphate if it's severe. Hyperphosphatemia would be caused by a number of things. Rhabdomyolysis is a common cause. Tumor lysis, typically when you see a high phosphorus in the setting of malignancy, you want to think about tumor lysis. Decreased renal excretion can occur in renal failure or hypoparathyroidism, and then increased gut absorption, and as in vitamin D intoxication and phosphate ingestion, sometimes following bowel cleansing. Treatment of hyperphosphatemia would be, first and foremost, low phosphorus diet. That's sometimes overlooked. So you want to have 50 milligram of phosphorus or less per serving. Patients will ask you that. How much phosphorus should I have? Which food should be avoided? So it'll be per serving, 50 milligrams of phosphorus or less, or 600 milligrams per day. So you can also treat hyperphosphatemia with phosphate binders. These will bind the phosphorus in the gut and get rid of it in the stool. The oldest phos binders were calcium-based, calcium carbonate and calcium acetate, also known as Phoslo. And then it was followed by Renagel, and subsequently by iron-based phosphorus binders, Orixia and Velphero. And then the newest is lanthanum. And then there are also even newer agents, which probably will not be tested. Hyperphosphatemia does improve with dialysis. So if dialysis is indicated, then dialysis support should be used. Next. So let's talk about hypomagnesemia really quickly. You want to think about thyrotoxicosis, parathyroidectomy. These would cause shift into cells. Diuretics are very common causes of hypomagnesemia. And then aminoglycosides, cisplatinum. These are common causes of acquired types of Gittelmans and Barters. And we'll talk about that. I spoke about those in some detail in the sodium potassium talk. And I think I will make some references to those later in this talk as well. Calcineurin inhibitors, such as tacrolimus and cyclosporin, are known for magnesium wasting. And of course, alcohol will cause magnesium wasting. And then Gittelman's is, of course, a hereditary renal tubular disorder, but it can be acquired. Insulin resistance, diabetes itself is actually known for magnesium wasting. So sometimes you'll see magnesium wasting and you'll think it's a renal tubular disorder, but it's actually secondary to diabetes. GI malabsorption, including decreased absorption owing to proton pump inhibitors. Then, of course, diarrhea and pancreatitis. And treatment of magnesemia is hypomagnesemia is oral or IV magnesium. And so this is not too difficult to correct. The oral magnesium dose is typically limited by diarrhea. If you need high doses, such as in Gittelman syndrome, typically you will need high doses of oral magnesium. The most common one used is magnesium oxide, and sometimes that can be difficult to tolerate. What I've found is that some magnesium compounds have high bioavailability and are less present in the stool, so they don't cause diarrhea as much, because obviously you have to be present in the stool in order to cause diarrhea. So if your magnesium is absorbed to a high degree, then it won't be present in the stool long enough to cause diarrhea. The one magnesium compound that probably has one of the highest bioavailabilities is magnesium amino acid chelate. Symptoms of hypomagnesemia are due to low potassium and calcium. So correction of potassium and calcium will be indicated. Next slide. Hypermagnesemia does occur. It's not so common and it's not so problematic usually, but it can occur with iatrogenic causes, decreased renal excretion, or bowel cleansing. Typically, it can cause some neurological symptoms, paresthesias, hyperreflexia, weakness, respiratory depression, although these actually are not so common. And bradycardia, hypotension, prolonged PR, and QT intervals on EKG and heart block have been reported. If they're asymptomatic, then you should use fluids and diuretics to increase renal excretion. If they're symptomatic, then magnesium basically blocks calcium receptors. So the antidote is intravenous calcium. And then again, dialysis if it's severe. Hemodialysis is only reserved for symptomatic hypermagnesemia. And dialysis usually removes magnesium efficiently, up to 50% reduction after a 3 to 4 hour treatment. Next slide. So let's do a question to stimulate our thinking. A 65-year-old woman is referred for evaluation of hypokalemia and hypomagnesemia. She recently completed concurrent radiochemotherapy for stage 3 non-small cell lung cancer. The chemotherapy regimen includes cisplatin plus vinblastine. On physical exam, the blood pressure is 110/60, the pulse rate is 96. There are decreased breath sounds at the left lung base. There is no edema. The remainder of the exam is normal. Laboratory studies show sodium 133, potassium 3.2, chloride 101, bicarb 29, BUN 32, creatinine 1.3 milligram per deciliter, calcium 8.9, magnesium 1.1, phosphorus 3.5, urine sodium is 72 milliequivalents per liter, urine chloride is 56, urine potassium is 65, and the urine calcium to creatinine ratio is 26. Dysfunction of which one of the following nephron segments is contributing the most to this woman's hypomagnesemia? So the magnesium is low, 1.1, very low. Urine potassium is high, and the urine calcium to creatinine ratio, as we will discuss, is low. What does that mean, and what does that tell us about what level of the tubule is being affected? Next slide. So again, findings are hypokalemia, hypomagnesemia, hypocalciuria, and urine potassium wasting. As you know, Gitelman's syndrome so I think of bloop, Barter's, and loop, and so Gitelman's would be thiazide. So Gitelman is a disorder typically inherited of the NCC. So acquired Gitelman's is actually also a disorder of the NCC, except the disorder of the NCC is not inherited. It's caused by cisplatin. And as you know, NCC is activated with thiazides. And thiazide diuretics act on the distal convoluted tubule. So Gitelman's would be a problem of the distal convoluted tubule. So the answer would be D. The main thing to remember is that in Gitelman syndrome, you would have hypocalciuria. And how do you remember that? It's because Gitelman's is thiazides, Barter's is loop. And so the thiazides, as we know, will reduce urine calcium, will cause hypocalciuria. And in Gitelman syndrome, typically the urine calcium to creatinine ratio is less than 44 milligrams per gram. And in this case, I believe it's reported to be in the 20s. So all of these findings can be explained by a disorder at the level of the distal convoluted tubule, in this case, because of cisplatin-induced acquired Gitelman's. Next slide. Let's talk about acid-base disorders. How do you approach acid-base? So the first step is to establish acidemia versus alkalemia. So you look at the pH. If the pH is greater than 4, it's an alkalemia. If it's less than 4, it's an acidemia. Next slide. Next step is to determine the primary disorder. If your primary abnormality is decreased bicarb, then it's a metabolic acidosis. If it's an increased bicarb, it's a metabolic alkalosis. If it's an increased PCO2, respiratory acidosis, and decreased PCO2, it's respiratory alkalosis. And then the compensatory responses would be a response designed to improve the pH to sustain life. So a metabolic acidosis because of a reduced bicarb would be expected to decrease PCO2, allowing the pH to come back to as close to life sustenance as possible. Next slide. So you should use a approach to determine adaptation, appropriate adaptation, and then just remember it and use it consistently. There are usually several approaches to determining propriety of adaptation. For example, in metabolic acidosis, the PCO2 can be 1.5 times the bicarb plus 8, or some people will say it's the last 2 digits of the pH, etc. In metabolic alkalosis, typically it's increase in PCO2 of 0.7 millimeters of mercury per 1 milliequivalent of bicarb. In respiratory acidosis and respiratory alkalosis, I just remember 1, 3, 2, 4. So in acute respiratory acidosis, you expect an increase in 1 milliequivalent per 10 millimeters of mercury of PCO2, versus in chronic respiratory acidosis, you expect an increase of about 3.5. And then in acute respiratory alkalosis, you expect a decrease of 2 milliequivalents per 10 millimeters of mercury of PCO2, whereas in chronic respiratory alkalosis, it's 4 to 5 milliequivalents per 10 millimeters of mercury of PCO2. Next slide. Now we should talk about anion gap. The most important thing to remember is that the number of positive anions must equal the number of negative ions. That's basically the science behind the anion gap. So in a typical setting, you're going to have sodium, potassium, calcium, magnesium, and then on the negative side, you can have chloride, bicarb, albumin, organic anions, phosphates, and sulfates. So the positive ions should equal the negative ions. So simplifying that, you would just say that sodium plus the unmeasured cations, because all these cations are unmeasured, and then is equal to chloride plus bicarb plus the unmeasured anions. So you essentially have sodium plus unmeasured cations is equal to chloride plus bicarb plus unmeasured anions. Now we all know that the anion gap is sodium minus chloride plus bicarb. So you can rearrange this equation and you get anion gap is equal to unmeasured anions minus unmeasured cations. And this is actually an important concept to remember. And this concept of unmeasured anions minus unmeasured cations also applies to the urinary anion gap, which we'll talk about a little bit later. And of course, the normal anion gap is about 10 to 12 milliequivalents per liter. Next slide. So determine acidemia versus alkalemia. Then determine is it primary metabolic versus respiratory. Determine compensation, but you're not done there. Determine the anion gap. That's the most important. They will hide the anion gap in the question, and if you don't check for the anion gap, you will not detect that there is a high anion gap metabolic acidosis. So if there is a high anion gap, then check the delta-delta. I use the delta-delta ratio, not the subtraction, because I feel that the ratio is typically more useful and more consistent and reproducible. So delta-delta is basically the change in anion gap over the change in bicarb. If the delta-delta is less than 1, this suggests a concomitant non-anion gap metabolic acidosis. If the delta-delta is greater than 2, this suggests a concomitant metabolic alkalosis. And if it's in between, it typically doesn't tell you anything, except for the statistic that in lactic acidosis, the delta-delta is typically 1.6. Next slide. So we'll talk about lactic acidosis. Whenever we talk about lactic acidosis, we're talking about type A lactic acidosis, which implies there's tissue hypoperfusion, as in sepsis or shock. And in type A lactic acidosis, you want to treat the underlying cause, and exogenous bicarbonate may increase PCO2 and may worsen intercellular acidosis. So exogenous bicarbonate should only be used for severe acidemia, as in pH less than 7.1. And typically, treating the underlying cause is sufficient to improve the acidosis. But obviously, if the pH is less than 1, that's life-threatening. So you will have to provide alkali support, sometimes even dialysis. Type B lactic acidosis is elevated lactate without tissue hypoxia or hypoperfusion. And we'll talk about where we can expect to see type B lactic acidosis. D-lactate is actually the mirror image of L-lactate. And basically, when you think of D-lactate, think of acetone. Any situation in which the acetone is elevated, the lactic acid elevation may be due to D-lactate elevation. Next slide. So type B lactic acidosis implies no systemic hypoperfusion, and there is impairment of cellular metabolism. Metformin is one of those etiologies. Malignancy and alcohol, HIV, mitochondrial dysfunction, nucleoside reverse transcriptase inhibitors, and then in the ICU setting, propofol, linezolid. And then there are some other acquired causes, and it can also be congenital. Next slide. So let's talk about type D lactic acidosis. As I said, it's a stereoisomer of L-lactate. Typically, you want to think about acetone. So you'll think about diabetic ketoacidosis. You'll think about short bowel, intestinal bacteria. Sometimes antibiotics can precipitate D-lactic acidosis because of lactobacillus overgrowth. And what happens is that the acetone is metabolized by the metyl glyoxal pathway into D-lactic acid. Propylene glycol is another etiology that you should remember. It's used as a solvent for some medications, and the treatment is bicarbonate if severe. And then oral antibiotics may help in short bowel syndrome. And then, of course, if there's propylene glycol involvement, then stop the propylene glycol. Symptoms that you can expect to see in type D lactic acidosis would be confusion, cerebellar ataxia, slurred speech, and memory loss. So symptoms are not due to D-lactate, but due to other toxins generated and absorbed in parallel with D-lactate. Next slide. False lactic acidosis does exist, and basically the glyoxylate, which is produced by metabolism of ethylene glycol, may cross-react with L-lactate oxidase used in assays performed with blood gas analyzers. Next slide. So ketoacidosis, as we know, can occur in diabetic ketoacidosis or alcoholic ketoacidosis. The beta-hydroxybutyrate to acetoacetate ratio is 3:1 in DKA and 7:1 in AKA. I just put that in there because sometimes that can be important to remember, that the ratio is 3:1 in DKA and 7:1 in alcoholic ketoacidosis. Next slide. Then we'll jump to toxic alcohol ingestions. Here there are some fundamental concepts to remember. The first is that you have the osmolar gap and you have the anion gap. The osmolar gap is the measured plasma osmolality minus the calculated plasma osmolality. So if there is a discrepancy between the measured plasma osmolality and the calculated plasma osmolality, then there's something there which is causing that discrepancy. The normal osmolar gap is less than 10 millimoles per liter. Osmolar gap more than 15 is usually critical, and but most osmolar gaps are between -10 and +10. Even lactic acid can elevate the osmolar gap, but it's generally less than 25 milliosmoles per kilogram because in lactic acid, cell breakdown will produce products of glycogen breakdown, which then elevate the osmolar gap. So, but here we're mainly interested in toxic alcohols. Now, toxic alcohols will elevate the osmolar gap because of the parent compound. So that's important to remember. You want to distinguish between parent compound and metabolites, because once the parent compound is fully metabolized, you won't have an osmolar gap. All you will have is the anion gap. And the toxicity that you see with toxic alcohols is due to the metabolites, not because of the parent compound. That's why if you have an osmolar gap, you want to prevent increase in the anion gap, i.e. increase in metabolites, and you can prevent that conversion of parent compound to metabolites by using fomepizole. If the osmolar gap has already resolved, then pretty much hemodialysis will be necessary to remove the toxic metabolites. So in methanol, ethanol, ethylene glycol, and propylene glycol, you'll have an elevated anion gap and osmolar gap. You do want to remember that in isopropanol, you'll have an elevated osmolar gap, but you'll have a normal anion gap. The other thing to remember is that in isopropanol, you'll have ketones, and your pH will be normal. So in isopropanol, you have ketosis without acidosis, and you'll have osmolar gap without an anion gap. So those are the critical points to remember from this slide. Next slide. Salicylates are important to remember. Basically, the salicylates usually will be associated with respiratory alkalosis plus metabolic acidosis. Rarely you'll see respiratory alkalosis alone or respiratory and metabolic acidosis, but those are not likely to be tested. They want you to remember that the classic finding of respiratory alkalosis plus metabolic acidosis. Symptoms that are common with salicylate poisoning would be nausea, vomiting, diarrhea, tinnitus, deafness, vertigo, fever, hyperventilation, non-cardiogenic pulmonary edema, and even seizures and coma. Treatment for salicylate toxicity would be alkalinization, which converts the salicylate to the ionized form, prevents diffusion of salicylate into the CNS, prevents reabsorption of salicylate by non-ionic diffusion, thereby causing trapping of the salicylate in the distal tubule. And in salicylate poisoning, you want to avoid intubation. If you have to intubate, then you should hyperventilate. Then you can use gastric decontamination, of course, correct the hypokalemia, and in severe cases, hemodialysis. Next slide. Methanol, you want to remember alcoholic feature, dilated pupils, retinal and optic edema and blindness. You can have rhabdo and pancreatitis. Keep the systemic pH greater than 7.3. This will convert formic acid to formate, which is less toxic. Provide folic acid, which will convert the formic acid into CO2 and water. And then hemodialysis support if the metabolites are excessive. Next slide. Ethylene glycol. You want to think about calcium oxalate crystals in the urine. The urine fluoresces under Wood's lamp. You do not have any alcoholic feature or blindness. You may see inebriation, congestive heart failure, ARDS, and acute tubular necrosis. Bicarbonate support is indicated. Fomepizole or alcohol can be used to prevent conversion. And thymine, pyridoxine. Hemodialysis if the ethylene glycol level is greater than 50 milligrams per deciliter, if there's acute kidney injury, or if the pH is less than 7.3 or decreasing with treatment, and if there's other evidence of end organ damage. Ethylene glycol is typically greater than 20 milligrams per deciliter. Osmolar gap is greater than 10 millimoles per liter, but typically much higher than that. And then, if you just have a suspected ingestion with acidosis and elevated osmolar gap, as well as calcium oxalate crystals in the urine, you should suspect ethylene glycol and treat urgently. Next slide. Isopropyl alcohol, as I said, is actually common because it's present in rubbing alcohol and hand sanitizers. Sometimes it might occur inadvertently. It is the second most common toxic alcohol ingestion. It is caused by rapid inebriation, followed by hemorrhagic gastritis. Hemorrhagic gastritis, you want to remember, that's the classic finding that they will want you to remember. And then the other thing to remember is ketosis without acidosis. It is sometimes associated with pseudorenal failure because acetone can falsely raise serum creatinine levels. So sometimes you may think you have AKI, but it's actually a falsely raised serum creatinine level. Treatment is supportive. Dialysis is almost never needed. Very rarely do you need dialysis. That would be in instances of persistent hypotension, lactic acidosis, or if the serum concentration is more than 500 milligrams per deciliter. Next slide. Let's talk about non-anion gap metabolic acidosis. Thing to remember is that in AKI and CKD, you're going to have a combination of high anion gap and non-anion gap metabolic acidosis. The high anion gap metabolic acidosis is due to accumulation of phosphates, sulfates, and hippurates. The non-anion gap metabolic acidosis is due to inadequate ammoniogenesis. So the way to remember the different causes of the non-anion gap metabolic acidosis is hard up, hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, ureterocolic fistulas, or pancreatic fistulas. Usually the other hyperalimentation, acetazolamide, ureterocolic fistulas, and pancreatic fistulas have typical presentations. The most common confusion is between renal tubular acidosis and diarrhea. Next slide. So we spoke about anion gap, and again in the urine we also have an anion gap. Here the anion gap is calculated with the urine sodium plus the urine potassium minus urine chloride. So obviously, like I said, you still want that equality between positive ions and negative ions, and you still have this relationship, unmeasured anions minus unmeasured cations. The one thing to remember is that the urine anion gap is typically negative in diarrhea, and it's typically positive in the remainder of the differential. It can be variable in proximal RTA, so urine anion gap is not that useful for proximal RTA. In diarrhea, obviously, you're going to have bicarbonate losses in the stool, so the kidney will conserve bicarb, and in exchange, it will secrete or excrete chloride, so the urine chloride will be high, and therefore your urine anion gap will be negative. Next slide. Let's talk about metabolic alkalosis. Metabolic alkalosis, you want to think chloride responsive versus chloride resistant. Chloride responsive means that the urine chloride is less than 10 and it will respond to normal saline. So here we're typically talking about contraction alkalosis, vomiting, NG drainage or gastric drainage, and then villus adenoma, congenital chloridoria, and cystic fibrosis. Treatment, as I said, is normal saline, and basically the volume expansion will decrease bicarb reabsorption. And then if you have a GI condition, you can use proton pump inhibitors as well. Next slide. Chloride resistant implies that the urine chloride is greater than 20 milliequivalents per liter. This generally means mineralocorticoid excess. The mineralocorticoid excess can be primary or secondary. So primary hyperaldosteronism, Cushing syndrome, and licorice ingestion are all associated with chloride-resistant metabolic alkalosis. And you can also see this in secondary causes of mineralocorticoid excess, such as renal artery stenosis, accelerated hypertension, and renin-secreting tumor. Next slide. The other causes of metabolic alkalosis that you do want to remember include hypokalemia. Hypokalemia is one of the most common causes of metabolic alkalosis. Basically, potassium depletion leads to shift of potassium out of cells and protons into cells. And there's also increased tubular bicarb reabsorption. And the treatment is to correct the hypokalemia, treat the underlying etiology, and then the entry of potassium into cells in exchange for protons will buffer excess ECF bicarbonate. Next slide. Finally, obviously, if you have hypercapnia, we all know that we should expect metabolic alkalosis. The CO2 movement into cells results in intracellular acidosis, resulting in increased tubular bicarb reabsorption. And in this case, you should treat the hypercapnia. Next slide. Chronic hypercapnia is an interesting scenario that you will see in the clinical setting. As you know, in chronic hypercapnia, whether it's chronic COPD, chronic emphysema, you have elevated levels of PCO2, so you have an adaptive increase in renal proton excretion and bicarbonate reabsorption. So you have respiratory acidosis and you have compensatory metabolic alkalosis to maintain a relatively life-sustaining pH. In this case, the sodium is reabsorbed preferentially along with bicarbonate, and chloride is lost in the urine. So they may ask you to know that the urine chloride is high. So basically what happens is that you have mechanical ventilation. So somebody with chronic hypercapnia gets sick. The patient is rapidly intubated and ventilated. You have a rapid restoration of the PCO2, but the metabolic axis is slow to catch up. So there's not enough time for change in bicarbonate handling by the kidney, and this may therefore result in severe alkalemia. Because of previous chloride depletion, the urine chloride is typically low. This improves with saline administration. So the treatment of this would be saline administration. Next slide. So we'll do a question. You're asked to see a 65-year-old woman with chronic obstructive lung disease and congestive heart failure in consultation for alkalemia. She was admitted with 2 days of increased dyspnea, fever, nausea, vomiting, and cough. Medications are ipratropium, furosemide, and enalapril. On physical examination, she is tachypnic with a respiratory rate of 24. Blood pressure is 90/60. Pulse rate is 108. Temperature is 38.3. Lung examination shows right basilar crackles, no edema. A dense right lower infiltrate seen on a chest radiograph. Laboratory studies show sodium of 140, potassium of 3.4, chloride of 85, bicarb of 35, BUN of 35, creatinine 1.2 milligram per deciliter, and glucose of 82 milligrams per deciliter. And ABG on ambient air shows pH 7.45, PCO2 54, bicarbonate 36.5, and PO2 of 52 millimeters of mercury. Which one of the following best describes this woman's acid-base status? So I'll let you think about it. Is it a simple metabolic alkalosis? Is it metabolic alkalosis and metabolic acidosis? Is it respiratory acidosis and metabolic alkalosis? Or is it respiratory acidosis, metabolic alkalosis, and metabolic alkalosis and metabolic acidosis? Next slide. So the pH of 7.45 indicates alkalemia. And the bicarb of 35 indicates the primary metabolic alkalosis. In this case, this would be due to a combination of vomiting, hypovolemia, potassium depletion, don't ever forget potassium depletion, and furosemide therapy. So these steps are relatively easy, and it's also the expected adaptation is also relatively simple. You would expect PCO2 to be about 47.7. And the measured PCO2 is 54, so there's a concomitant respiratory acidosis. This is likely due to chronic severe COPD, and acute pneumonia may also be causing acute and chronic respiratory acidosis. Finally, don't forget the serum anion gap. The anion gap is elevated at 20 milliequivalents per liter, so there's a high anion gap metabolic acidosis. This is likely due to organ hypoperfusion, sepsis, and type A lactic acidosis. So the answer is D. Next slide. You're asked to see a 60-year-old woman with transfusion-dependent myelodysplastic syndrome, hospitalized for weakness and newly documented hypokalemic metabolic acidosis. Her medications are ruxolitinib and deferracerox. The physical examination shows a normal blood pressure and pulse, pallor, no edema, and mild diffuse weakness. Laboratory studies show sodium 138, potassium 3.4, chloride 109, bicarb 19, BUN 18, creatinine 1.3, glucose 86, calcium 8, magnesium 1.6, phosphorus 1.1, albumin 3.8, total protein 6.6, uric acid of 2.8, leukocyte count of 2,500, hemoglobin 6.3, and platelet count of 32,000. Urinalysis shows pH 5.0 and trace protein. A venous blood gas shows pH 7.32 and PCO2 of 36 millimeters of mercury. The daily urine ammonium excretion is 40. The urine phosphate level is 25. Urine creatinine level is 100 milligram per deciliter. The urine protein to creatinine ratio is 400 milligram per gram, and the albumin to creatinine ratio is 30 milligram per gram. A urine electrophoresis shows low molecular weight proteinuria. No monoclonal spike is present on urine and serum electrophoresis. Which one of the following is the most likely diagnosis? Hypokalemic distal renal tubular acidosis, tumor-induced osteomalacia, spurious hypophosphatemia, bicarbonate loss through the gastrointestinal tract, or proximal renal tubular acidosis. So here you have a primary metabolic acidosis, and the anion gap is 10, so you should always check what the anion gap is. So this is a non-anion gap metabolic acidosis. You have a low serum potassium, low serum uric acid, and a low phosphorus, and the fractional excretion of potassium is high at 30%. Remember, like as we discussed, the low urine pH and fine are indicative of proximal tubular injury and makes distal renal tubular less likely. So remember that in proximal tubular acidosis, you have bicarbonate loss, but ultimately the distal tubule is able to reclaim the bicarb so that the final pH is actually low. In distal renal tubular acidosis, the pH is typically higher, typically greater than 5.5. Tumor-induced osteomalacia will cause hypophosphatemia without metabolic acidosis. Spurious hypophosphatemia would not be associated with renal phosphate wasting and acidosis. And then GI losses of bicarbonate would generally be associated with low fractional excretion of phosphorus and higher level of ammonia excretion. So the answer is proximal tubular dysfunction. And in this case, this is supposed to be due to deferracerox therapy, but you should be able to answer that regardless. Next slide. 24-year-old woman with cystic fibrosis is hospitalized for treatment of Pseudomonas pneumonia. Her hospital course is complicated by ileus, requiring nasogastric suction. 12 days into her hospital course, she develops paresthesias and diffuse muscle weakness. Her medications are pancrelipase, fat-soluble vitamins, calcium carbonate, insulin aspart, high-dose ceftazidime, and gentamicin. On physical examination, the blood pressure is 110/80, and the pulse rate is 102 per minute. The lung examination shows inspiratory crackles at the right base. There is no edema. Laboratory studies show sodium of 138, potassium of 2.3, chloride 93, bicarb 34, BUN 39, creatinine 1.3 milligram per deciliter, calcium 8.4, magnesium of 1.2, phosphorus of 3.2. Venous blood gas shows 7.43 pH, PCO2 of 53 millimeters of mercury, urine sodium is 78, urine chloride is 68, and the urine potassium is 52. Which one of the following is the most likely cause of this woman's acid-base abnormality? Is it nasogastric suction? Is it gentamicin, post-hypercapnic alkalosis, sodium chloride loss in the sweat, or ceftazidime? Next slide. So whenever you think about hypokalemic metabolic alkalosis and normal to low extracellular fluid volume status, you should think about diuretics, gastric fluid loss through vomiting or nasogastric suction, and Gitelman's and Barter's. So again, Gitelman's is thiazide, Barter's is loop, so that's bloop. And then gentamicin can be gentamicin can cause acquired Barter's, and cisplatin can actually cause Gitelman's. So that's how I remember that. And then high-dose penicillin therapy can also cause hypokalemic metabolic alkalosis. Next slide. So here, the most likely diagnosis is acquired Barter's due to gentamicin. So Gitelman's and Barter's are actually quite rare because they're inherited disorders, they're tubulopathies, and they're very rare. But acquired forms are actually quite common, typically gentamicin and cisplatin. So aminoglycosides are divalent cations that activate the calcium sensing receptor in the thick ascending limb of the loop of Henle. As a result, intracellular cyclic adenosine monophosphate production decreases, resulting in increased arachidonic acid. Arachidonic acid inhibits ROMK and NKCC2, causing inhibition of sodium potassium chloride reabsorption and abolition of the normal lumen positive potential in the thin ascending limb. As a result, a loop diuretic effect ensues that also inhibits calcium and magnesium uptake via the paracellular pathway. So this is bloop due to gentamicin. Next slide. The most important thing to remember is Barter's and loop and Gitelman's and thiazide. Bartter-like syndrome, which is caused by calcium sensing receptor activation, is distinct from isolated NKCC2 or ROMK dysfunction, which does result in hypercalciuria. The acquired form can be associated with urinary calcium and magnesium wasting. Bartter-like syndrome associated with aminoglycosides persists for about 2 to 6 weeks after discontinuation of gentamicin. So during that period, you should monitor vigilantly and supplement potassium, calcium, and magnesium. And after 2 to 6 weeks, the Bartter-like syndrome will resolve. And that cystic fibrosis, they threw in the question because we don't actually know whether aminoglycoside-induced Bartter syndrome is increased in patients with cystic fibrosis. Next slide. Nasogastric suctioning can cause metabolic alkalosis and hypokalemia, but it's also characterized by low urine chloride. Therefore, option A is incorrect. Both urine sodium and chloride levels are low in post-hypercapnic metabolic alkalosis, and individuals with cystic fibrosis can develop hypovolemia and metabolic alkalosis from excessive sodium chloride losses in the sweat, particularly during the summer months. However, urine sodium and chloride levels should be low. Next slide. Penicillins, so the idea of non-reabsorbable anions is important. Bicarb is one of those anions, and so if you have alkalosis for any reason, the bicarb will be excreted by the kidney, and potassium will follow the bicarb. Similarly, penicillins can act as non-reabsorbable anions, and that can result in excretion of potassium and hydrogen ions, causing hypokalemic metabolic alkalosis. This is not known to occur with ceftazidime. So our question mentioned ceftazidime, but did not mention penicillins. Next slide. So that's all for this talk. Join me next time, and we'll talk about acute kidney injury and chronic kidney disease.